All right, everyone, it's 8 o'clock, so we can get started on our next presentation. We have Wayne Lyon, the Director of Health Information Management Coding at Keck, and Jeyson Flores. Is Jeyson with you? He's the Director of HIM Clinical Documentation Integrity at Keck, and they're going to provide us with some DRG coding information.
Kim, thank you. And Wayne and Jeyson, I want to thank you guys for coming. If I could just do a very brief introduction as to why this is relevant. So I think everybody in this audience knows that when you do a surgery, you have to put in a CPT billing code and submit it. And then you get paid based on that. And so some CPT codes have higher pay rates than others. Now, if you do an outpatient surgery or a surgery with a 23-hour observation, the hospital also gets a fee for that surgery based on the CPT code that you submitted. So for all of our outpatient stuff, it's whatever you CPT code. You get some, the hospital gets some. Now, if you do a surgery where the patient has to stay and get admitted to the hospital for more than 23-hour obs, then you still bill your CPT code, but the hospital starts billing a DRG code. So that's what they're going to talk about today, is what the hospital bills for inpatient stays. And this DRG code is super relevant, which I didn't appreciate for many years, but it's super relevant for two reasons. Number one, US News and World Report rankings are based upon DRG. I mean, they don't care about CPTs or your outcomes for outpatient surgeries. They only care about your outcomes for inpatient surgeries. And number two, if the hospital makes more money off of your inpatient surgeries, then they're likely to give back some of that to the doctors for programmatic support. And because nowadays CPT codes aren't enough to keep a doctor practice afloat. You need some kind of revenue from the hospital in some way. And so DRG coding is really important. So that's why we're having this today. Wayne, are you here? Jeyson? Nobody?
They're here. They're
Yes,
both here.
Oh, you are? Okay, good.
Yes, there they are. Perfect. Yeah, you should be able to share your screen, so whenever you're ready. And they sent me the materials, so I'll be able to send those out to everyone after.
Okay.
Thank you.
I'll share my screen right now.
Perfect. Thank you.
Thank you.
So this is Wayne. Can I be heard? Just a mic check.
Yes, we can hear you.
Okay, wonderful.
Okay, thanks.
Sorry, I'm having some.
And Kim, you're going to record this, is that correct?
Yes, it's recording right now. So yes, thank you.
Okay.
Can you see my screen?
I can't see the
we
presentation.
see the windows. We're not seeing the presentation. We're seeing the Windows logo.
Just let me try again. Technical issues here. Oops. We're so used to Microsoft Teams that I don't know how to use.
Usually in Zoom, somebody has to give permission for others to share their screen. Is that?
Yeah, we have it set up so you should be able to share, but if you'd like, I could. Okay. I know you sent me the materials. Do you want me to try to share?
Yes, please, until I
Yeah,
figure
go
this
ahead,
out.
and we'll just say next slide to you as we
Okay,
go.
should I start with the PDF, the PowerPoint, or the PDF first, the PowerPoint?
It's
The PDF first,
Okay,
and then the PowerPoint, we're going to switch to that depending on some of the points we have to make.
okay. Let me then. Okay.
Okay, so welcome everyone. This is Wayne, and as the coding director here at Keck, I have about 60 individuals doing all the coding for clinic and the hospital side for the hospital billing. There's a separate coding team, some of you may know, that does the USC Care Pro-Fee coding and billing, and we're not in that space. So today we're going to talk about the DRG grouper logic and algorithm. And inside of that, we're going to talk about MDC, DRG, and ICD-10 coding, so the ICD-10 diagnosis and ICD-10 procedures, which might be new to some of you. In the DRG algorithm, CPT and HCPCS are not used. Okay, so CMS have a different procedure coding tool, that is the ICD-10 PCS. Next slide. And we're going to divide the discussion in two parts. The first 30 minutes or so, we're going to go through the slides. There are 50 slides, so we're not going to go through every single one of them. But we want you to have everything so you can review it at your own leisure. And then the second 30 minutes, we want to show you how this DRG algorithm works live in some of your ENT accounts. We're going to show you how that works. And then during that time, we could address a lot of your Q&As. And you can interrupt us with questions at any time. Jeyson and I will flip between slides. There are some slides that he's going to discuss, others I'm going to discuss. But we want to get through the slide within the first 30 minutes so that we could give you live demonstration inside of our coding system that we're using right now. So this is pretty much the learning objective, and basically number 2 and number 3 is where we're going to talk about a lot. The Medicare Severity Diagnosis Related Group came about in 1983, and pretty much that's how Medicare pays all inpatient stays. And then a lot of commercial payers adopted it and a different DRG system called APR-DRG. We're going to mention that as well. And so number 3, we're going to just talk about the algorithm, the methodologies, and the workflow. Next slide. Jeyson.
Yes, and as Wayne showing in the prior slide, one of the key aspects why Dr. Otolaryngology asked us to do this presentation is because the DRG does have many implications. It's not just the reimbursement for the hospital. Nowadays, many entities such as US News and World Report, VCM, Health Grades, Leapfrog, Medicare, they pull all these data and do an analysis and risk stratify patients and rank hospitals, rank specialties, and see how hospitals are doing from the complications standpoint, such as patient safety indicators, core measures, readmissions. So DRGs, as we explained before, have many other implications. It's not just attached to reimbursement to the hospital. Next slide, please. Next slide.
So now we're going to talk about some of the laws surrounding this. Next slide. So basically everything coding, and this is just one of the regulations published by CMS, is governed by federal law. Okay, no hospital has any say over how this works, and they cannot customize it. It's one coding system, laws, regulations, rules, and guidelines for the whole nation. And physicians have to follow it in their coding and billing. Hospitals have to follow it. Clinics have to follow it. And you'll notice the call out is pointing to the red highlight, adherence to these guidelines when assigning ICD-10 CM diagnosis code is required under HIPAA. So HIPAA is a federal law, and what the feds did was they also put under HIPAA everything having to do with ICD coding, DRG, CPT coding, HCPCS. This particular guideline is for the ICD-10 CM coding, but we just wanted you to understand what we're going to talk to you is regulated and cannot be customized by the hospital. Next slide. So here is a brief description of one of the regulations. It's under Uniform Hospital Discharge Data Set. And this one defines the principal diagnosis, which we're not going to get into the definition, but this is just to illustrate to you. And this was published in the Federal Register in 1985, as you can see. So it's all federal. It's all federal, and states have their own. Next slide. And the next slide talks about the same regulation, but speaks to the secondary diagnoses and when and why we code all other conditions. And these two conditions, and I didn't put the slide for the procedure, so I will update the slide and send it to you. But these three data becomes some of the critical data that goes into the MSDRG algorithm and the APR-DRG algorithm. Next slide. Next slide. So we're going to take you through some of the workflow. So Jeyson?
Yeah, so the DRG grouper, specifically the MSDRG, which is not for Medicare Severity Diagnosis Related Group, is solely owned by CMS. And there are three main components that affects the DRG. One, as Wayne mentioned before, the principal diagnosis, which is defined as the condition that is chiefly responsible for the inpatient admission to the hospital. And additionally, the secondary diagnosis or additional comorbidities that the patient may have, such as patient can be admitted for laryngeal cancer, and the patient at the same time may have diabetes, hypertension, coronary artery disease. So those are defined as a secondary diagnosis. The third component are the surgery that the patient underwent. So those three main components are going to define the actual DRG for that inpatient admission. But also the DRGs can be affected by CCs and MCCs. You may have heard about CCs and MCCs. CCs stand for comorbidities and complications, and MCCs stand for major comorbidities and complications. But it's important to remember that not all comorbidities are considered CCs or MCCs. Medicare provides a very specific list of what they consider a CC and what they consider an MCC or a major comorbidity. And we will not go into details, but you can really tell now how DRGs can be affected by three main components: principal diagnosis, secondary diagnosis, procedures, and the presence of CCs and MCCs. Next slide, please. And this is just a graph that defines the algorithm of the DRG. As you can see on the top, the three main components: principal diagnosis, secondary diagnosis, procedures, and also gender, age, discharge status may affect in some situations. And then all combined together will determine the DRG in the middle side. Medicare versus medical DRG. We'll now focus on medical DRGs. That's a different point, which is APR DRGs. It's a very similar to the Medicare, but there are significant differences. And then we have the MSDRG, which we have about 760 MSDRGs. And just to reinforce again, hospitals only get paid for a single DRG during the inpatient stay. It doesn't matter if the patient stay 1 day, say 1 month, or even more. Next slide, please.
So this one is just reiterating what Jeyson just described. We won't spend much on this slide, but the second to last bullet point, I'll draw your attention to that, because this is one of it's the initial component of the MSDRG algorithm, the major diagnostic category. There are 25 of them plus a few that are not numbered. And this link below, if you could open that. So we're going to use the link to give you an illustration and what CMS does. And you could go to the next slide as well. But Kim, if you could click on the link as well and bring that up in your web browser. So this is what we're going to show you. Yeah, click that link and then the next slide at the same time. So we're going to show you this interactively. The link is at the top as well. But these are the MDC, major diagnostic category, and they're body system based, right? So you can see MDC 3 is the ears, nose, mouth, and throat diagnoses and surgeries. And you can see the MCC lists that Jeyson spoke about just now. And also we're going to describe the surgical hierarchy list. And this gives you an idea of how 3M constructed this DRG, not 3M, the government, CMS, constructed this DRG algorithm. And they posted it on their website for anybody to go in and discover how it works and, kind of play around with your specialty. So if you could bring up the website real quick, Kim. Okay, so the way this works is once you identify the principal diagnosis and say it's an ENT diagnosis, you're going to click your MDC. So if you could click MDC number 3, and it explodes into all of the DRGs under that MDC. The first section, it's when surgery is performed. You'll see to the below that the categories of types of surgery, and to the far right, you will see the DRG numbers, right? And then the section below the surgical section, you'll see in the black highlight, is the medical DRGs. It's when no surgery is performed, or a procedure is performed, but it is not going to affect the DRG. So when a procedure is performed that does not affect the DRG, it's considered a medical DRG. And the section above that, when the surgery impacts the DRG, it's considered a surgical DRG. So we're going to open one of the surgical ones. If you could go scroll back up to the top, Kim, and just click the first major head and neck. Yes, that one. And it explodes into all of the operating room procedures and the ICD-10 PCS codes that goes into that particular ENT DRG. So these first 3 DRGs, 140, 141, 142, and we're going to walk you through a demo of this live in our system. All of these surgical codes, and as you can scroll down, you'll see lots of surgical codes. It's a ton of them. And sometimes, it continues on additional pages, right? So it goes on forever. And if you're not familiar, these are the ICD-10 procedure codes. They're very different than the CPT and HCPCS codes you may be used to. And the description is we consider this description kind of strange. It's certainly not how physicians speak most of the time in their operative report. But what the system does, it has 32 root operation, and the first word in each description is one of those 32 root operation. So if you describe your surgery as you know, an occlusion or ligation or whatever of a carotid artery, for example, the system will code to the root operation occlusion and then the anatomy, and if any device was left in, or if no device were left in, if it's the percutaneous approach, open approach. But that's the procedure coding system that drives this. When you use this tool on the far right, you will see 3 blue arrows. The up arrow that's pointing up takes you backwards. So let's go back and go back one more time. And you can minimize this, but we wanted to give you this, and let's go back to the slides, the PowerPoint slides. No, so I wanted to give you that illustration. And if you want to see all the diagnosis in the CCMCC, you could visit that. Next slide. And this slide is talking about the surgical hierarchy. I won't dive into this too much, except to say that what Medicare did was they said, here's a list of all surgeries that impact DRGs. And the one that is higher up on the surgical hierarchy list will drive the DRG. So sometimes you will do an ENT surgery, right? Very definitive surgery for cancer or some correction. That surgery is on the hierarchy list, it will drive the DRG. But if the patient deteriorates and say they have breathing problems, respiratory failure after the surgery, and you got to put them on a vent and then put them on, give them a tracheostomy later. The tracheostomy is the 4th highest on the hierarchy list of thousands and thousands of surgeries. So the tracheostomy being higher than your ENT surgery, the tracheostomy will now drive the DRG, not your ENT surgery. We're going to give you a demonstration of that live so you can see how it works with and without tracheostomy, but we wanted to introduce the surgical hierarchy list to you that Medicare designed. Next slide. Now, the coders begin their job. This is the coding workflow. And based on physician documentation, H&P consultation, op report, progress notes, discharge summary, and all of the diagnostic reports physicians create, we don't code from any other notes except physician notes. The coder will assign the principal diagnosis, all the coexistent diagnosis, comorbidities, complications, etc. The coder will also assign the ICD-10 PCS principal diagnosis and any additional, principal surgery and any additional surgery that's done. The coder uses guidelines, federal guidelines and sequencing laws, rules, and regulations to do this job. And then the system, once we put all that data in, coupled with the age, gender, and the discharge status, the system generates the DRG, right? So the coder doesn't decide the DRG. Every coding system vendors and billing system vendors for the hospital side have to purchase this DRG grouper algorithm from CMS, which is updated every October. So they do this every October and put it into their system. And that's why it's one grouper for the whole nation, right? And so when we put in these information, the system generates the DRG. And that's essentially the workflow. Next slide. So here, we're going to give you a live of this. And Jeyson, could you describe this? It's the 3 different DRG system, but this is an image of the system we're going to give you a demo on. Jeyson?
Yeah, this is just a screenshot of the system I will show you, but basically it's describing the system calculates 3 types of DRGs at the same time. It will depend the insurance on the patient. If it is a medical, it will calculate the APR DRG. If it is a Medicare or a commercial insurance that pays under MS DRG, it will provide the Medicare DRG. And also there is a separate APR DRG that is used nationwide. Next slide, please. This is your area, Wayne.
So this is the coding software. So when the system generates those DRG, it passes into our coding system, because we have two different coding systems, the one that we code inside of and the one that stores the data. This one stores the data. It's HCM. It's another 3M product. And it passes the data into our billing system. And as you can see, it has 4 separate DRG fields. The 4th one is the one that's going to go out on the claim. So that's all programmed into our system. Next slide. So this that we're going to go through is a manual understanding. If you're doing this stuff manually, you'll understand it. So we're going to fly through these screens. We don't want to spend a lot of time on these. Next slide. And go next slide. Okay, so this is a flow diagram for how the DRG algorithm works. You start off with a principle, could be any of those, and as the coder codes, did the coder assign a comorbidity that is on the MCC list? Yes or no? For example, if the principle is pulmonary embolism, yes or no? It depends on what is assigned. It takes you into that DRG. Next slide. This is a surgical version of that. So you have your pulmonary DRG or respiratory principle diagnosis, but say it got to a point where OR has to come in. You'll see how it switches from a medical DRG. When you assign the surgery, it switches to a surgical DRG. And it begs the same question. Did one of the diagnoses turn out to be a CC, MCC, or not? And it puts it into the right DRG. Next slide. This is a different service line. This is the digestive system. Same thing. Next slide. We're going to go through these ones real fast. And this is a OR on the hepatobiliary system. You'll see how it flows with the different categories of DRGs. And there's sometimes more categories for a service line. A different service line might have less DRG categories. Next slide. This is one where a medical case or a surgical case could drive the DRG. So I'm not going to go through this because we're going to give you a demo, but just to give you a different illustration of a different service line. Next slide. I want to get through these parts very fast. Now, your ENT service line, when we first engaged Dr. Ogilai, we focus on ENT service line in terms of how the DRG is ascertained for ENT surgery. Next slide. And this slide is just to show you where ENT DRG are. Most of them are in NDC3. However, once you start operating on the lymphatic system, depending on the diagnosis and the procedure, it could put it into a different MDC. And this is some of the weird quirkiness of the DRG system. You think everything should fall neatly into the anatomy, but the body system being operated on, once it's lymphatic or a different body system, it quickly turns into a different set of DRGs. And this sometimes is unexpected. But Jeyson will go through some examples of that. Next slide. And this is just an illustration, another illustration of how it works. We're not going to go through this in the interest of time, but for your edification, you could review it at your leisure. Next slide. And Jeyson, do you want to touch on these a little bit? This is the lymphatic one. Thank you.
Yes, I think we will show an example, but again, like Wayne said, it depends the area of the ENT anatomy that you are doing a procedure on. And one of the cases that we discussed in detail with Dr. Ogilai were those situations where the patient have a prior, for example, laryngeal cancer underwent laryngectomy several years ago, but now the patient seems to have a recurrence and have a new mass in the neck. And then you perform surgery on these patients, and there is metastasis of the prior laryngeal cancer into the lymphatic nodes in the neck. So these DRG typically will drive to an MDC related to the lymphatic system instead of an ENT DRG. Next slide, please.
Next slide.
Well, the same thing. Next slide, please.
So these ones we didn't want to, oh, go ahead, Jeyson.
Just the details, right? If a particular patient undergoes, again, resection of the lymphatic nodes in the neck, it will drive you typically to a DRG 821, which falls under MDC 17. These details about which is explained. This is also a screenshot of the encoder, the system that calculates the DRG, and just seeing details about the particular case where the patient have a, as you can see in the blue side, secondary and specified malignant neoplasm of the lymph node of head and neck, right? And underwent resection, neck dissection, how that DRG drives to 821, and again, MDC 17. Next slide. Give me just more details about the same thing. Next slide. Probably we'll just do it live. I'll try to share my screen again to see if I can really show you the system. This is a situation where the principal diagnosis can be a cancer of the tongue, how the DRG will play out in that situation, and then when glossectomy and, I'm sorry, pharyngectomy and glossectomy, right? And resection, all at the same time, dissection of the neck, how the DRG will play out. It will be a DRG 129. And it will depend also whether the patient have a CC and MCC. Any secondary diagnosis, I mean, any metastasis from a primary cancer will play a role of a CC. And that's what we're illustrating here in this case too. You see, after the principal diagnosis, there is a secondary diagnosis, and that plays a role of the CC. And that's why this DRG is with CC. Next slide, please. Wayne, do you want me to?
We're going to try to switch to the live system now.
Kimberly,
so
can you try again and see if I can?
Can you do that, Jeyson?
Yes.
So,
I stopped sharing.
okay.
Let me know.
Okay. Let's see. Okay. Can you see the encoder?
Seems to be working now. It's coming up. It's slowly coming up. It says Jeyson has started. Okay, now it's up. Wonderful. Okay.
Okay, good.
So good.
All right, so let's pretend, and I will delete these codes, but I would prefer Dr. Ogalai or anyone would like to share a typical case that you will see. But let me just go through this particular case first, and then probably you can drive and I can show you how a clinical documentation specialists are calculating the working DRG during the inpatient stay. And that's something that you will be able to see in Cerner, right? And how that DRG can progress to a final DRG when the patient is discharged. Because if you remember, DRGs can be affected for the main three variables, right? And when explain a very common scenario where patient undergoes surgery, but at the end cannot be extubated and then get tracheostomy probably by the end of the discharge. So this is a particular case that have cancer of the larynx, right? That's the reason why the patient got admitted and will undergo surgery. Undergo laryngectomy, and at the same time, this is the procedure that I'm showing right here in ICD-10 codes, and also bilateral neck dissection, right? So this is the DRG that you come up with this diagnosis and these procedures. But let's start over. Patient admitted for laryngeal cancer. This is a DRG. This is a medical DRG. But then you do the procedures, and this is the way we do it. This is the way the coder and the CDIs will calculate the DRG in a particular case. Oops, sorry. So undergoes laryngectomy. The system will ask you, was a total laryngectomy or it was a partial? Let's pretend it's partial. What's the approach? It was open, percutaneous, right? Let's pretend it's open. And then it will ask you, there was any accompanying procedure to the laryngectomy? So let's say it was a neck dissection, bilateral, right? And let's say there are no more procedures. So we calculate the DRG in this case scenario and see how the DRG now moved to a surgical DRG, right? But it doesn't have without CC and MCC because the only diagnosis that we have coded is cancer of the larynx. But let's pretend the patient, when the pathology report comes back and we see that the lymph nodes are positive for cancer, right? So we will not code that. And in ICD-10 codes, metastatic cancer, the synonym is secondary cancer. So we'll call it secondary cancer of the lymph nodes in the cervical or the neck. We can spell it out either way, right? And let's see how that DRG moves higher. Now is with CC because that secondary cancer now plays the role of a CC. And you may have noticed how the weight increases the DRG. The DRG weight, the higher the weight, the higher the reimbursement for the hospital and the higher the complexity of the patient. If I remove, you can notice the difference in the DRG weight. If I remove this code, it goes to 1.6. But if I add it back, it's 2.2, right? But let's say the same patient have a low weight, have poor oral intake, muscle wasting, hasn't been eating well, have lost a significant weight, and we discovered the dietitian have documented severe malnutrition, so you will get the query to clarify whether you believe the patient have malnutrition. So the same patient, and you specify that the patient has severe malnutrition, how that plays in the DRG. Now you have a DRG with MCC because severe malnutrition is considered a major comorbidity by CMS. And you see how the weight went from 2.2 to 3.98, right? Increased the weight significantly. But then let's pretend that this patient got worse, you couldn't get it extubated, and you didn't do a tracheostomy up front, but later on you had to perform a tracheostomy on this patient, right? So we're gonna code the tracheostomy and let's see what happens. See, like Wayne explained, now the tracheostomy is higher in the hierarchy of the CMS, and that's the one drives the DRG and moves it from a tracheostomy for face, mouth, and neck diagnosis DRG. And you see the weight, 5.01. And also, I forgot to mention about the length of stay also increases, the expected length of stay, which is the GMLOS right here. But let's pretend the same patient. So since you keep it on mechanical ventilation, you kept the patient on mechanical ventilation for more than 96 hours. So we're gonna code the mechanical ventilation for more than 96 hours. See what happened? Now we have a DRG3, and what's the weight of the DRG? Almost 19. So this is the progression of an inpatient stay. We keep adding diagnosis and we keep adding procedures until we fully represent all you have documented in the medical record. But it's important to clarify that the only things that can be coded and reported for hospital purposes is only what is documented by physicians in the HMP, progress notes, OR report, consult notes, and discharge summary. So documentation from nurses, respiratory therapists, dietitians, those don't count unless the respective physician documents those diagnoses in the notes. I don't know if you would like me to go into any particular case that will be interesting to you to go through this game of assigning codes. Dr. Ogaray, anything in mind?
Oh, yeah, thanks, Jeyson. Thanks, Wayne. I mean, I don't have a specific patient. Most of these are head and neck, are on the head and neck service. I don't know. Do you guys have a patient you'd like to review? I mean, you can't do one from this week because they probably haven't done the coding, but I would figure a couple weeks ago they should have the coding.
So we'll switch because we're doing it live. We're going to delete everything, and you could spell out your case and we'll code it as you speak.
I have a more general question. One is the tracheostomy changes the DRG. Is that DRG an ENT related one, or is that grouped to a different specialty?
Yes,
well, it certainly took it out of, yeah, go ahead,
yes.
Jeyson.
This for when you do an ENT procedure, typically will land into this DRG. This is just, it is an ENT DRG. The problem is when
you'll see the MDC right below the DRG number. You'll
right
see
here,
the MDC, and that tells you it's in the ENT stratification.
Yeah, the only time when tracheostomy will not go to this DRG is when you have a non-ENT diagnosis, such as, let's say, pneumonia, for example, as the principal diagnosis. If I had pneumonia as the principal diagnosis, you see it goes, let's remove the tracheostomy. It goes to different DRGs. So,
and the MDC is different now. The MDC
exactly.
is respiratory instead of ENT.
If the principal diagnosis is an ENT diagnosis, it will move to an ENT DRG.
Wait, Jeyson, what if you have pneumonia and they consult us to do a trach, and then we do a trach and they're not on the vent for more than 4 days? Is that an ENT DRG then?
No.
With the trach that we did?
No. This is the DRG for pneumonia. It's simple pneumonia, right? That's the principal diagnosis. So let's go tracheostomy. It will go to DRG4, which is not an ENT DRG. So tracheostomy formation, let's say it's open, right? See, go to DRG4, which is not an ENT DRG.
Oh, because it has, okay, so greater than, or principal diagnosis accept. So for Mark, for your question,
exactly.
If you're doing a head and neck case and you do a trach, it stays the ENT diagnosis unless they have the mechanical ventilation greater than 96 hours. And then, then it goes out of our DRG.
I see. And then 2 more quick questions. One would be, are free flaps considered an ENT DRG, or does that switch us over to a plastic surgery one?
Yes, typically it depends if you at the same time did a ENT procedure. Most likely the ENT procedure will drive the DRG, but if the main procedure that you did was the flap, most likely will go into a plastic surgery DRG.
Well, they're usually combined with a head and neck cancer. So
let's code a case like that so we can actually see.
Did you do one this week, Mark?
Yeah, I can find one.
Yeah, if you just say the name.
No, I mean, even you can tell us exactly what you did in any particular patient that you would like to find out. We don't really have to see a real case.
You can do mandibulectomy and fibula free flap and trach.
Okay, let's so what was the diagnosis that the patient was admitted for?
Oral cancer.
So oral cancer. Okay, let's go that cancer. Spell site, oral cavity. It will ask a specific what site, but we can say unspecified.
Okay.
Let's do you have the site specifically?
Gum, I guess.
Okay. See how the system keep asking you specific question when we don't have that information as a coder in the CDI?
Mandibular, use
Yeah,
mandibular.
Number 3.
Okay, so that would be our principal diagnosis, right? I'll delete the rest of the code so to avoid any confusion, right? So this is our DRG so far, right? Now we're gonna add mandibulectomy, right?
Mm-hmm.
Is a partial or is a complete mandibulectomy?
I don't know what that means, but I guess complete.
The left and the right.
Doesn't matter.
See, all these questions, they will ask in the system. So we had to find that information.
How can it be a total mandibulectomy if it's right or left? I mean, isn't that
the coding system divides the mandible in right and left. So if you do a complete right, that would be considered a complete. So it's considered separate bilateral. Yeah.
Okay, but
if they do the whole thing, we would code the left one as well.
Yeah.
So sometimes the PCS system gives bilateral, and sometimes it says left or right, and sometimes it's left and right because it doesn't give a bilateral option. But there's a lot of laterality in the ICD-10 PCS coding system.
Okay.
Okay, so that's what we have so far. We still need an ENT DRG. Now you did a flap, right? Pre-flap, right? Graph?
Yes.
Flap.
Yep.
Is skin, subcutaneous tissue and fascia, muscle, or what type of?
It'd be osteocutaneous.
Osteocutaneous.
So bone and skin.
So we have to code it separately. So that means, okay. We had to code skin and then the bone. Where did you take the graph from?
The lower leg.
Okay, hold on. The skin graft replacement site. I think this is asking me for.
That is where the graph went. I think that's where the graph
so it went to
the head neck number 5.
Yeah.
Okay. And it's the neck. Okay. Number 4.
Autologous tissue substitute.
From the same patient, okay. Useful thickness for this demonstration.
And then it will ask me on the more skin graft replacement.
Any more sites, and that's where the bone would come in if that's an option.
Yes. Now we want to add the bone. It was from the lower extremity. Oh, sorry. That's the site.
Is that to or from? That's where it went.
No, it's the harvesting, right?
Oh, the harvesting. Okay, so the harvesting. Where did the bone come from?
It comes from from the leg to the jaw.
What the bone specifically? Do you remember? Do you know?
It'd be fibula.
And then we accept these and code the bone graft separately.
Mm-hmm.
So this is the quirkiness of the ICD-10. It's 78,000 codes in ICD-10 procedure, and it's very granular. And they ask us to code each component of the procedure separately. Whereas in CPT, one single code could cover all of this. In ICD-10, we have multiple codes that explain the whole procedure. It's more granular than the CPT.
It seems like it stays still in the ENT DRG. And let me clarify something, Dr. Swanson. I think Dr. Swanson, right?
Yes.
There were a lot of DRG changes in October 1st. And my understanding is that many of the DRGs that in the past were moving to plastic surgery because of labs, now they put them in the right categorization of DRGs. So now, even though you did a graft, but because you did the resection of the mandible, it still stays in the ENT DRG. If I am not mistaken, prior to October 1st, 2020, that used to go to a plastic surgery DRG.
Yes, that is correct. And Dr. Ogla, if you recall, the October DRG changes by the feds, the ENT was the biggest of all the changes, and we did share that with you, if you recall, Dr. Ogla.
Yeah,
and
no,
so now we're seeing, say that again?
Yeah, that's good. I mean, our volumes are going to go way up because we do a ton of free flaps, and I think we weren't getting credit for that.
Right. So previous to October 1st of last year, for 5 years, all of those would never fall into an ENT DRG. Obviously, there's a lot of feedback from the surgical community. And CMS, what they did for fiscal 2021, which begins October 1st for Medicare fiscal year, they created 6 new DRGs just for ENT. And they move a lot of the procedures that used to fall in many other DRGs, they move them under these new 6 ENT DRGs, one of which you're looking at now. If we coded the same thing under a discharge date before October 1st of last year, you would see a totally different shocking result. So that's a major improvement in the DRG system that Medicare did. So if you run ENT DRG data before October 1st, you're not going to have a high volume of ENT surgery because some of them fall into non-ENT DRG. But if you run your data after October 1st, you will be much more satisfied going forward.
Thanks for showing that. And then one final question. If a patient has an ENT DRG, you know, for example, a head and neck cancer and free flap, and then they get sepsis, does their DRG change, or is it still?
No, it doesn't change the DRG because that's not the reason for admission. It might impact the CC and MCC because I added.
Let's do that, Jeyson. Let's add sepsis.
Yes, I'll show that. I added as like this patient will have a lymph node met, so that added a CC, as you can see there, right? This DRG was without CC and MCC, so I added the secondary cancer or the mets, and that will add a CC. Let's pretend this patient developed sepsis after surgery, right? So what will happen? There are 2 key aspects to remember to this. One, let's pretend that we have sepsis unspecified. First, you get an MCC, which makes a DRG higher. But there is a more important implication related to this. There are certain diagnoses that are considered complications of care. And the main ones that we can point out are the PSIs, so patient safety indicators. Because these type of surgeries typically are elective, right? That means that patients should not develop postoperative infections. So if patient develops sepsis, affects the payment, but it dings you from the quality standpoint. Because this will be
add the
a
POA
complication,
and let's.
will be a PSI 13, which is a complication of care. So, and that's the reason why you sometimes may get the query asking, doctor, you know, someone else might have documented sepsis, but we're asking you, does the patient have, do you believe really that the patient has sepsis, or is probably the aspiration pneumonia that is causing the manifestation that the patient may look septic, but probably just the aspiration pneumonia instead of just sepsis and aspiration pneumonia, right? I mean, that's a clinical decision that you have to evaluate. If you remove the sepsis from this case and you leave the pneumonia, you still have the MCC with the pneumonia, but you don't have the complication of care, at least the ones that are really affect complications rate for the hospital and the specialties. So that's the good point about clarifying certain diagnoses such as sepsis or pulmonary embolism, for example. That's considered a complication of care. The patient develops post-op pulmonary embolism, that would be a PSI 12. Or if the patient develops postoperative hemorrhage or hematoma, right? But there are some exclusions to that, like postoperative pulmonary, post-op hemorrhage. If the patient had coagulopathy or had thrombocytopenia or had platelet dysfunction due to aspirin, for example, right? And it develops postoperative hemorrhage or hematoma, just by having that additional comorbidity coded will exclude the case from PSI. Oops, sorry, I have some. My system was trying to disconnect, okay.
Jeyson, if you could add the POA next time
Yes.
and put sepsis back in, let's see if the hack comes up and the PC.
So if this patient develops hematoma, postoperative, let's say, is skin and subcutaneous tissue. This procedure by itself will trigger a PSI 9 if obviously it's not present on admission and developed after the surgery, right? And that's what Wayne is talking about, the present on admission. When we assign the codes, we assign what we call POA, or present on admission. And it will ask you, was the malignant neoplasm lower gown present on admission? Obviously, yes, right? Was the aspiration pneumonia present on admission? Most likely not. So we have N, which means no. Y stands for yes. U stands for unknown. W stands for clinical, unable to determine. And E means exempt. Some codes are exempt from this reporting. So secondary malignant neoplasm, obviously yes, was present on admission. Post-procedural hematoma most likely was not, because developed after the surgery, so we'll assign N. And thrombocytopenia, we don't know. We have to clarify depending on the documentation, but let's say yes, right? So if this post-procedural hematoma has a POA no, this will trigger a PSI 9. And same thing with sepsis. But if sepsis is present on admission, then it's not. I don't know if that.
Put sepsis back in, Jeyson. Let's see if what happens.
A419, just to be quick. So we have to assign the POA, whether it's POA yes or no, right? If we assign no, this will trigger a PSI. And that's the reason why sometimes you get these type of queries. Would you please clarify the severity of the infection? Aspiration pneumonia only, aspiration pneumonia with sepsis, aspiration pneumonia with sepsis and septic shock. Because, you know, many times there are other doctors co-managing the case and they might document sepsis, but at the end, based on CMS rules, who has the final say is the attending physician. And that's why we go to you to clarify and tell us whether you concur with the diagnosis or not. Any more questions?
Does transfusion affect this?
No, it doesn't affect the DRG and doesn't affect from the quality standpoint, but it has to be coded. So we still code it from the hospital standpoint. So it's a quality. I know that there has been a lot of discussion about patients with acute blood loss anemia and a lot of transfusion during the hospital stay, but that's a hospital implication, quality implications, but doesn't have anything to do with the DRG or the payment to the hospital.
So that's one of the procedures, transfusion, that is not on the CMS surgical hierarchy list. So when we code it, it has no impact on the DRG. But we have to code it. Any other questions? And just briefly.
Oh, sorry.
Oh, go ahead. Go ahead.
Please excuse my primitive understanding, but this increase in the DRGs that are ascribed to ENT, isn't that also going to affect the mortalities and morbidities that get ascribed to ENT-related surgery?
You touch an excellent point correctly. Typically, from the DRG standpoint, we only need one MCC to make the DRG the highest possible in the weight, right? Only one MCC. If we only have aspiration pneumonia in this case, that's all we need for the DRG to be from the payment standpoint, from the revenue standpoint. But as more comorbidities you add, the higher the risk of mortality. And that's something that Vizient and the US News and World Report also track, right? If the patient have more comorbidities, diabetes, hypertension, hypothyroidism, depression, obesity, malnutrition, all those, we have to code them and report them. It will not impact the DRG, but it will impact the risk stratification models out there. And that's where the risk-adjusted mortality index comes from. And there are different ways to measure mortality. One is in-hospital mortality, and there is a 30 days mortality. US News and World Report uses a 30 days mortality risk. Encoding and reporting all coexisting comorbidities during the inpatient stay will definitely impact that risk, that is calculation of risk of mortality. So excellent question, yes.
And just to touch on one other brief thing. So we didn't talk much about the APR DRG, but right below the MSDRG on your screen, you'll see the APR values. And the APR, a lot of commercial payers uses it, but one part of the algorithm is it scores the severity of illness, and it has a risk of mortality score. And it's only 4 levels, 1 through 4, 4 being the most severe. But as we add these comorbidities and CC and MCC codes, the risk score is being altered until finally, when we're finished, that would be the outcome. The risk stratification used by Vizient and World News and Leapfrogs and all of those, they have their own proprietary risk mortality strategy and stratification. So, but internally, this is the only one we have, the APR DRG.
And this also plays the role of the Elixhauser. Can you still see my screen for Elixhauser, Wayne? Just want to verify. Wayne?
Yes, yes,
okay.
We can see
so
that.
This is the risk stratification model that U.S. News and World Report uses. They consider 29 category of diagnosis, and all these plays a role in their calculation. We don't have a meaning to calculate these, but they do it in their way. But they tell us as much comorbidities these patients have, the higher the likelihood of dying. So documenting this diagnosis, you know, will have a definitive impact on how U.S. News and World Report rank specialties and hospitals. Simple things like obesity, weight loss include malnutrition, dehydration is included under fluid and electrolyte disorders, right? So depression, you know, there are 29 category of diagnosis. I think we are over time, but we are happy to stay. It's up to you if you have more questions. Just be respectful of your time.
We love the Q&A section, so please ask anything. Okay, so no more questions. So that's pretty much the full presentation. We gave you the PowerPoints that will be sent separately by Kim. And Kim, if you could wait, I'm going to add one more slide and send it to you again.
Yes, no problem.
And we gave you a live demonstration. And at any time you can reach out to either of us via email or phone call if you have any questions that might pop up. So thank you very much for your audience, and I hope this was meaningful to your processes and workflow, although it's mostly the hospital side.
And feel free to reach out anytime if you have any questions. We're happy to help.
Perfect. Thank you so much. We really appreciate it.
Thank you.
Okay, thank you, everyone. Have a wonderful day, and I'll send out the information as soon as I can. Thank you so much.
Thank you.
Bye-bye.
Bye.